The American Society of Addictions Nursing is a new organization. We are growing by leaps and bounds, and it's rather exciting. And we put together this weekly webinar series that has run from July 6th through August 28th. They are 1-hour webinars that start every Tuesday promptly at 7 p.m. and that's Eastern Time. We do want to thank our sponsors, in particular, Recovery Management Solutions, who is the one that has powered our Zoom platform, and we're very appreciative to Suzanne Kinkle for this. You want to keep your camera on, but you want to mute your microphone throughout the presentation. Usually in your picture field, if you go to the left corner, you will see where you can mute your microphone. You want to post questions in the chat box only. I will, at the end of the presentation, go into that chat box and post the questions to our presenters. In order to get CE, you're going to want to complete the daily session survey. The link to each session survey is on the schedule page in our website. This conference has been approved for a total of 8 nursing contact hours through the California Board of Nursing, and that is if you attend all 8 sessions. Each session is worth 1 hour of CE. I can tell you when you complete your evaluation, instantaneously you'll get your CE certificate to your email address. All of the sessions are being recorded. We are in record mode right now. So participants who cannot participate in our live sessions are more than welcome to listen to the recorded session, and you also, if you complete the survey, will get continuing ed for that as well. I want to introduce you to the Asam Board of Directors. Bill Carrick is our president. Susanna Looney Kinkle is our vice president. Bill Lorman is our treasurer, and Ginny Coletti is our secretary. And board members are Carolyn Baird, Fran Campbell, Mary Armstrong Fagier. Again, every Tuesday we host this webinar through next week will be our last webinar. Today, we will be doing common psychiatric disorders and co-occurring disorders with substance use disorders. And I am happy to introduce, and I'm going to put my specs on for a minute, Dr. Diane Snow and Dr. Virginia, we call her Ginny Coletti. So I will start with Dr. Snow. She's been contributing to psychiatric and addictions nursing for over 35 years as an educator, researcher, and in professional service. She is retired from the University of Texas at Arlington, where she was a clinical professor and director of the Psychiatric Mental Health Nurse Practitioner Program. And she has many, many wonderful accomplishments listed in her CV. Which I'm not going to read the whole thing, but just to name a few awards. She received the Education Award and the Living Legend Award from ISPN and the Research and President's Awards from INSA. She's also a fellow of the American Association of Nurse Practitioners and the International Academy of Addictions Nursing. And Dr. Ginny Coletti, she is a clinical associate professor at Stony Brook University School of Nursing. She also has many wonderful accomplishments. She's been a nursing leader in the field of addictions nursing. She has served as the chairperson of the Addictions Nursing Certification Board, ANCB. Her belief is that every nurse cares for patients whose lives are touched by the disease of addictions. Therefore, she's worked to incorporate a strong foundation of addictions nursing into undergraduate and graduate nursing curriculum, as well as advocating for trainings in screening, brief intervention, and referral to treatment. With that said, I am going to stop sharing my screen so Dr. Coletti can share her screen, and we will have both presenters tonight.
Okay. So this evening, we are really hoping to be able to cover all of these objectives so that we are identifying symptoms of psychiatric disorders, as well as looking at screening tools and medications, briefly treatment for all the co-occurring psychiatric disorders that we have listed here. We hope to cover major depression, bipolar, anxiety disorders, general anxiety disorders, panic disorder, obsessive compulsive, PTSD, ADHD, and hopefully, if we have time, we have a case study from the tips to be able to share with you. So Diane, you want to chat a little bit about co-occurring disorders?
Okay, so we know that people with psychiatric problems often struggle with substance use disorders, and they really go hand in hand. And many times it's not just a dual diagnosis, it may be that they have several psychiatric disorders and as well as several substance use disorders as well. So it is a complex issue that we have, being able to manage our patients well and help them get a good recovery from all their disorders and all the things that they've either inherited or that they've developed. And so we have at least 8.9 million people who are adults with co-occurring disorders, but not very many, approximately 55.8% almost receive no treatment at all. So that's a high number and something we hope we can change through knowledge and through teaching others about getting an accurate diagnosis and being able to assess correctly. Another issue often is that our 12-step programs or other support groups often don't take into account the people with multiple disorders. And so we want to make sure we get an accurate diagnosis and treat all the disorders, either at the same time or at least get the diagnosis and then be able to treat at the appropriate time. So we don't wait to treat the disorders. Okay, Ginny.
Great. Oops. Okay, so major depressive disorder. Truly it affects a tremendous number of people. And what I really hope to cover in the next few minutes is to look at what are we looking for, why do we look for major depressive disorder, how do we look for it, and then what do we do about it. So whether you're working in a substance use disorder treatment or you are working for a mental health facility, odds are you're going to encounter people who have a co-occurring substance use disorder and a major depressive disorder. It's not always easy to know the difference because what happens, the affective symptoms tend to hide sort of within each other, and they both share a lot of those same social, occupational, cognitive, and the emotional functioning that all are affected by both disorders. Okay. So I thought I would just briefly start off by going over very, very quickly what we're looking at in terms of the DSM, and we look at the symptoms of major depressive disorder. We recognize that you have to have a loss of interest and a loss of pleasure, and then for at least 2 weeks, and then 4 out of these other 7 symptoms. But sometimes we want to think about why do we have to look so hard for this? Because they do overlap. We know that approximately 1/3 of the patients with major depressive disorder also have a concurrent substance use disorder, but it's not always that obvious. What happens is these patients tend to have more mood disorder symptoms. They tend to have a greater difficulty in sleep. They tend to feel a higher level of worry and worthlessness. They also have a higher risk for suicide. So the comorbidity here has been shown to have greater suicide attempts and a much higher suicide ideation. So we've also looked at that, mental and social impairment that comes with this. Again, when there's a comorbid disorder, a co-occurring, we have more anxiety, and in general, you could just say there's a greater disease burden. I think sometimes what happens is we wonder whether or not what came first, like chicken or the egg. Was it the major disorder, or was it the substance use? But when you really start to think about it, it doesn't matter. The fact is, this population is at risk. So the initial presentation of depression can really mask some of the overriding symptoms of substance use, and vice versa. From the research that I looked at, I've seen that a number of different areas where they are really, there's a reluctance to sort of treat that depression right away. Many times they'll require a period of abstinence before treating the depression. But waiting that length of time, that also can have consequences. So finding a good diagnosis is very important. And we don't want to have to wait too long. What can happen during that period of abstinence is you can have increased symptomatology, increased symptoms related to suicidal ideation or a suicidal attempt. So that greater burden is placed upon the patient by making them wait. We also really want to make sure that we have taken the time here to really look at it. Take time to look at this patient and explore all the different areas. So when do you screen for somebody? As I say, a lot of people in treatment or provide treatment are looking at, well, we should wait first and see that the symptoms from the substance use disorder have mitigated. But finding out what's happening with that person as quickly as possible is really what you want to be able to do. You want to wait until the person has detoxed. But after that, then you want to start to think about, okay, now what about looking a little bit further? What about checking what is the baseline here? So when a patient comes in for an intake, we really want to be able to get a really good history as soon as they're able to give us that history, and not to wait, not to take time to sort of see whether or not the symptoms of depression will abate as the patient has greater abstinence. So different things that we can keep in mind when we are doing that searching, that assessing, to see whether or not there is that co-occurring disorder going on. And there's been a lot of research to look at some of the distinguishing baseline characteristics. That is definitely something that has out of the STAR-D study. They looked at it and they found that distinguishing baseline characteristics very, very clearly for the comorbid personality, for the comorbid major depressive disorder and substance use disorder were that younger adults, male, either divorced or never married, non-Hispanic, and those that really endorsed a greater functional impairment related to their illness. That these were classic pieces of data that would tell you whether or not you should look further. So what we're really looking at here is to find out what do we want to look for? What flags tell us that it's time to look a little bit further? Family history is another big area. Family history really is one of those things that, without question, can indicate whether or not there's been trauma in the family, whether there is a somebody turn that microphone off, please. To find out whether or not you have a history of depression, whether you have a history of alcoholism, what is going on in that family. Those are important because we really have found that if you get a good history, you find out what's going on, that collecting that data as soon as possible will really produce the best treatment plan and the best outcome for the patient. That's what we're aiming for. So we look for these red flags. Also, clinical features. With this particular population, we recognize that the depressive symptomatology might be a bit more exaggerated. We also know that suicidal ideation is very much evident there. You're going to see a lot of it. And although it may feel a little bit like Monday morning quarterbacking, what you will see here is that if you look at treatment outcomes from past treatments, and then you take a look at what's going on as we continue in treatment, that there is definitely a realization that adequate treatment for the depression, for the major depressive disorder, really reduces the substance use disorder. And I have to say, there's also been research that has gone the other direction as well, that treatment for the substance use disorder has shown significant decrease in symptoms from the major depressive disorder. So screening tools, there are a number of them out there, but these were the two that I thought were the most, they were the ones that seemed to be used the most. They seem to really cover a good area, and both screening tools revealed very similar presentations. But there were some differences when I went through the research and looked at them very carefully. The screening tool for the Patient Health Questionnaire 9 really seemed to detect a higher rate of mild depression. So if you're using the Beck's Depression Inventory, which is a little bit longer, it's 21 items, whereas the other's only 9, but the Beck's Depression Inventory, it didn't give as much validation to the mild symptoms, whereas the Patient Health Questionnaire seemed to accent even mild depressive symptoms. So it would give you a better picture of what was going on with the patient at the time, particularly one that had just finished a detox or one that was coming in and looking for services, and you're really trying to determine whether or not there is a depression on board there. Either screening tool would provide excellent results. You know, they both are going to give you great information. It just depends on which one might be easier for you to utilize in a different clinical setting that you're in. So the next question on major depressive disorder and substance use disorder has to do with treatment. What kind of a treatment approach are we going to utilize? Literature talks about 3 main conceptual treatment approaches: the sequential, the parallel, and the integrated. And they are very much what their title talks about. The sequential is one disorder at a time. And in the parallel, here you would have 2 different clinicians treating the same person. They would look at both, each one would look at a different disorder. One would take the major depressive, one would take the substance use disorder, and the treatment would go forward. Problem here is that, you know, coordinating all that treatment sometimes can be a problem. So when we start to look at the integrated approach, you have one single clinician or treatment team, right? And they are both treating this person. So they're both, this whole team is working with this one person, looking at both the depression and the substance use disorder. These treatments usually combine a psychosocial therapy along with a pharmacotherapy. So that brings us to our next slide here. And I'm watching my time very carefully. There are a number of different medications that can be utilized here to treat the major depressive disorder along with the substance use disorder. And these are the ones that I found most mentioned in the literature. What I do want to say is to go through each one of these would really be outside the scope of this particular presentation, but we will take questions on it at the end. But I'd like to finish up really just kind of bringing a point home that antidepressant medication is very useful, and that the literature does support that utilizing both the psychosocial interventions along with the pharmacological interventions is the best way to go. We want to keep in mind that interventions to promote recovery from addiction are important, as well as those interventions that stabilize the environment. These are really essential when it comes to successful treatment. So you need to think about that person in the environment in which they live and all of the other pieces that come into it. Diane, I do believe you're up next.
Okay, I just wanted to tag on a little bit of thought about major depressive disorder and the other disorders we're talking about. Remember the DSM-5 has the category called substance-induced mood disorder, substance-induced anxiety disorder, and so forth. So when would you make that diagnosis versus MDD? So there are times when you need to think about that, and that would be if the symptoms only occur while someone is using drugs or alcohol, or shortly thereafter. So if the symptoms were not there before, during a period of time when they were not using, and that's one of those ways you can ask people, is to say, during a time when you were not using, did you have these symptoms? And when you're talking about MDD, a current or bipolar current history or current symptoms, you would then check to see if they only started during the actual time when they were using drugs. And sometimes that's hard to tell because they may have been using drugs for, all their life since they were 10 years old or something. So sometimes it's really hard to find a time when they weren't, just to determine, is this really so? But the support usually is that if it's over a long period of time, they've had these symptoms, and it's likely you could go ahead and diagnose it as a separate MDD or separate bipolar disorder. Okay, so another mood disorder is bipolar disorder, and just to emphasize the fact that it is inherited in almost all situations. The genes, so when it says the genes account for 79 to 93% of the risk, that's a huge indication that bipolar disorder is a genetic inherited disorder. So what do we need to really check on is, their family history. Their first degree relative would be either a parent or a child or a sibling, or even the second degree relative, aunts, uncles, cousins, and so forth, to get that family history. Almost always you can find someone in their family who has these symptoms. And lots of times they've never been diagnosed, but you still ask the same questions as if they were having. Are you all seeing that update on the? Okay, I guess it's not for my slides. All right, so as many as 3.9% of the population at any given time have bipolar disorder, and some of the literature supports up to 5% if you stretch it out to just a very mild manic, hypomanic episodes. So it is a chronic mood disorder involving episodes. So when we talk to people, we talk about their episodes of mania or the episodes of depression. The mean onset is around 21 years of age, but it can start in early childhood, and often with sleep disturbance or more like depressive symptoms in early childhood. Again, it does run in families, so that if both parents have bipolar, there's a 50 to 75% chance that a child will have it as well. Can you go back one slide, Ginny?
All right.
Okay, thank you. Now, so we look at genetics, and then we look at the psychosocial factors or the environmental factors that contribute. And so we ask the question, does stress and childhood adverse events contribute to the cause of it? And certainly they do, and they found that physical and sexual abuse are much higher in the population of people with the bipolar disorder than other people. So they have cataloged the genes for bipolar disorder, which is an amazing thing that's happened in our lifetime. They involve glutamate, serotonin, BDNF. You familiar with BDNF? So brain neurotropic factor, and it's a good thing. We want to have as much BDNF as possible. It helps heal our brains after trauma, after inflammation of some sort. So we're looking at the process of even a bipolar disorder having a inflammation category to it, and BDNF decreases the inflammation and is low. This is interesting. It's very low, which is not good, right, in mania and depression, but it's normal. It normalizes for the most part in euthymic time. So, people have episodes, but they're not always in depression or mania. So they may be in what we call euthymia, or a normal mood. So during that time, the BDNF normalizes, which I think is very interesting. The literature supports that THC, this is not related really to bipolar, but increases BDNF, but not if they use every day. So it's not saying we need to encourage people to smoke marijuana, but it's just a finding they have of why perhaps people, report feeling calm and so forth. There is also an association between binge drinking, low BDNF, and anxiety. If you're interested in more about that, there's some literature on how you can increase it, like through exercise and, healthy exposure to the sun, breathing fresh air, omega-3 fatty acids. In fact, we did a bipolar study adding omega-3 fatty acids to bipolar medications when I worked at the bipolar research program. And we actually found it did help their mood symptoms. And that was many, many years ago. So it was a theory even back then, but we didn't know why or what we were really after at that point. Okay, next slide. So the neurobiology, this is just one of the things that goes on is this, what we call excessive neurotransmission. So I think people understand or can think about their brain being almost like a motor in a car, and starts misfiring. So it causes a hyperexcitable brain when the person, especially when they're going through mania. And this glutamate flows in and is activated, which is an excitatory neurotransmitter, not good for us to have this much glutamate. And this causes at the cellular level for calcium to flow into the cells, which, by the way, does cause some neuronal death also. It's neurotoxic to the cells. And so the brain can't shut off, and then the person will admit to having racing thoughts, or maybe their mind is a flight of ideas in how they talk. But most everybody with manic mania can tell you when they have racing thoughts. So over time, that's so exhausting to the brain that the neurotransmitters get depleted, and that causes then the depressive phase. And maybe just suddenly
I wiped it out.
starts up again.
Thank you.
So the brain needs neuroprotection, as you can imagine, from all this excessive glutamate. And the mood stabilizers and the medications that we provide are really the main source of treatment for bipolar. Episodes occur again, by stress, from drug and alcohol use. Even the different seasons can cause that. So, okay, you can switch to the next slide, please. So we have, lots of people with both, right? I mean, that's one of the most common co-occurring disorders with substance use is bipolar. Up to 59% of those with bipolar disorder have substance use disorder in their lifetime, especially if there was this is kind of interesting, an early onset of bipolar. So a child or teen onset are much more likely to get into drugs or alcohol, which makes sense when you think about experimenting and the impulsivity of, especially during mania. So a lifetime occurrence ranges from 21.7 to 59% for individuals with bipolar disorder. And so it's not only people that have full-blown bipolar, but also people with hypomania can also have an increased risk for substance use disorder. People often start self-medicating their mania or their depression with drugs and alcohol. And I always say, if you have the genetic tendency towards addiction, then that's going to become another disorder that you're going to have to deal with, and that is your drug abuse. So, and then the shared genetic vulnerability, that a lot of the literature shows that if someone doesn't have a history of bipolar in their family members, they asking about a history of substance abuse disorder, especially alcohol use disorder, has shared genetic vulnerability. So that's kind of one of those researchable topics at this point. So we just recommend treating the medical, the substance use, and the bipolar disorder at the same time. You can't send someone out from treatment with an active mania and expect them to not use again. I mean, you're going to have a lot of potential for relapse unless that mania or the depressive phase, whichever they're in, gets treated. Or they may switch. There's a common term called switching. So they really do switch, often very suddenly, from one episode to the next. Now, the episodes have to last a certain length of time to have a true diagnosis of that episode, but you'll see people, as you're talking to them, even if they're depressed when you start talking to them, they may get manic as the session goes on. Okay, go ahead, the next one. Okay, so screening, the MDQ, it's not the best tool in the world, but it is easy to use, and it's 13 items, and doesn't diagnose or rule out the depression. It rules out mania and hypomania. And it's especially helpful when the patient presents with depression, and you're trying to figure out how am I going to treat this person and what is really going on, because it's just screens for it, but so a further assessment needs to be done. But the problem is, if you treat a person with bipolar disorder with the same treatment you would for MDD, you could stimulate that person to have mania. And most people will say they've been treated for their depressive symptoms for years with antidepressants and never been properly evaluated for bipolar. And yet, so they never have gotten well from their depression. So that's one thing so you're always looking at the history, as well as the questionnaire and so forth, a screening tool. But so you ask the person, was there a time when you were not using drugs or alcohol and you experienced these symptoms? So your history is so important, and you'll hear that over and over as we talk. So, okay, go ahead. So the manic episode, the next slide, has many possible symptoms. It has to last a week in order to have a true manic episode last 7 days or more. So that would be what we call full-blown mania. It's a distinct period where their mood is elevated or just real expansive, or it might be just irritable. And during that time, they also have increased goal-directed activity and high energy. One way to evaluate their mood is to use a scale of 1 to 10, with 5 being stable or level mood, and then above 5 being manic and below 5 being depressed. Most people can do it, even though it's hard sometimes to self-report, especially if they are manic. But for the most part, people are able to tell if they have at least, if you describe it to them a little bit more. So the high energy, high goal-directed activity. So they may be super focused on spending money, starting new businesses, 2 or 3 at the same time, working on dangerous projects without rest, determined to do things despite the consequences. And they may have high libido, high sexual energy at the same time. So they get many consequences from this in many cases. Fast talking, so they may self-report that's oftentimes the earliest symptom they notice when they're getting manic is they're talking more than usual. Like they might be a real quiet person, but when they're manic, they're talking all the time, and everybody says, "What's wrong with you?" Or they may be like doing things out of character, like taking everybody to lunch and paying for it, which they never have done unless they're going up into a manic episode. Or they may feel pressured to keep talking, so call that pressured speech. And that's something you observe. It's not something they can really report, but you hear that almost like a motor or train in their voice. It's very pressured. Flight of ideas or racing thoughts. So that we talked about that a little bit, just extremely distractible. They can't focus on their work. Then they get involved in activities with potential for painful consequences, the way the DSM-5 talks about that. So people who never spend extra money. I remember one patient that went to Walmart all night long and spent, all this money she never, didn't have the money, but she had her husband's, I think it was credit card or something. Anyway, I always say to my patients, At least leave the tags on the things you buy. So when you're not, when you realize what you've done, you can take them back, you know. Okay, the next one, please. Thank you. All right, so but there's a bipolar 1 and bipolar 2. Bipolar 1 means they've had a full manic episode at some time in their lifetime. They may or may not have been hospitalized, and they may or may not have had depressive episodes. You actually have people who have never had a full-blown depressive episode. Bipolar 2 has at least one major depressive episode lasting 14 days, but they haven't had the full-blown manic episode, and they haven't been hospitalized for mania. Okay, let's go to the next one. The medications, I just kind of listed them all. This is for mania. We know about lithium. It's a salt that occurs in our bodies and water and everything, but it is a good treatment. But usually we combine it with an antipsychotic. That's been the way it's been approved for mania. Valproic acid is Depakote or carbamazepine with an antipsychotic. Or you could just use monotherapy, olanzapine, which is ipraxicoptiapine, typine XR, and so forth. So the cariprazine is the new Vraylar, the Vraylar, and then this is Saffris. So all these medications are approved by the FDA for acute mania. Haldol has been used for many years. It's a first generation, old, very inexpensive. And I know if you work in an emergency room or, psych stabilization unit, you're often going to use Haldol to treat it. And it does really work pretty well. So can we tell people that they can get off their medicine once the episode's over? No. So if they say, am I going to have to be on this the rest of my life? Well, you don't want to just say, yes, you are, and you better get used to it. But we do say, this is a chronic relapsing illness, and just like substance abuse is a chronic relapsing illness. And so we use medication to help you prevent new episodes. So some of these medications that I've listed here are also approved for preventing new episodes. Other treatments involve, just regulating their schedules to get adequate sleep, adequate nutrition, monitor their mood, all those 1 to 10 kind of things. There's lots of apps now we use, and to monitor their symptoms and to call for help if their mood suddenly switches, because they may not be adequately treated if they go into a full-blown mania and they just had an appointment yesterday when they weren't in that mania. Okay, go ahead. So the depressive episodes have a little bit of different treatment, but it doesn't mean that you would change everything if they drop into a depression. But you might consider if a person is is coming to you or in the hospital with bipolar depression, starting with these medications. So again, lithium, but then Latuda is approved for bipolar depression. That's an antipsychotic. And then lamotrigine, which is Lamictal, which is anti-epileptic drug, that's approved for preventing new episodes. And then your Sequential and Sequential XR approved for, and then combining olanzapine with fluoxetine, and then Depakote and lithium together. Suicidality is very high with these patients. And so you have to be very cautious to add some statistics on it, but there's a rate of 20% of people with bipolar disorder will actually commit suicide, and they often will use lethal methods. So the rate of attempts is extremely high, and the rate of actual suicides is very high in this population. So we have all the more reason to be very, very careful in diagnosing and getting them adequate treatment. And it's hard because sometimes the illness keeps them from knowing that they need help, right? So, okay, go ahead. Next one. So now switch over to the anxiety, which we're including GAD, panic, and OCD being commonly occurring disorders we see with this population. GAD is, you think, well, okay, so people have, no, this is really, really very common. 2.9% of adults. The genetic risk is 31.6, so always get a family history. The childhood adverse events are a strong contributor, such as abuse or neglect, being in foster homes or whatever might contribute to their being unstable and psychosocially. So the symptoms, excessive anxiety and worry is the number one thing. So they're very apprehensive and about a number of activities or events, like what's going to happen at work, what's going to happen at school, their health, finances, family. Depends. Sometimes it sort of relates to their age as well, because health usually is more in the older population. They also need to be able to say, yes, they have difficulty controlling the worry if you're able to make this diagnosis. 3 or more, you see people, they've had shoulder pain or arm pain or back pain, and no explanation for it. It's muscle tension. And if you ask, or headaches that are muscle tension headaches, that's very, very common. Feeling restless, keyed up, they're sitting there with their legs constantly in motion. Easily fatigued, difficulty concentrating, or their mind goes blank, irritable, and sleep disturbance. And it's not due to a drug or abuse, medication, or physical condition. This is one of those statements that the DSM-5 makes on every single disorder. So if it is due to a drug or abuse, then it would be the substance induced, like let's say it's alcohol-induced anxiety disorder, that kind of thing. So, okay, next one. And I didn't put the screening for GAD, but there is a GAD-7. But the symptoms are pretty easy also to ask patients about. So the panic disorder, PD, call that. This is when they have more than one unexpected, out of the blue, panic attacks. And a panic attack is an abrupt surge of intense fear or discomfort. And within a matter of minutes, it's reached its peak. So it's not something that lasts all day long. It's quick onset, and 4 more symptoms. There's 13 listed in the DSM-5. So a couple of them are sweating, palpitations, nausea, and so forth. Persistent fear of another attack or the consequences, fear of losing control, having a heart attack, or going crazy. They'll often end up in the emergency room to start with, and then they are told, you're not having a heart attack, so perhaps you need to get help for panic disorder. It's not caused by a drug of abuse, or medication, or physical condition again. 2 to 3% of the population have panic disorder, and it is highly inherited. So ask about family history. CBT helps quite a bit, breathing, yoga treatment, anything to get that breath quieted down and not hyperventilate, so forth. Okay, next slide. How are we doing on time? Let's see. Okay, let's see. We get the one with this treatment. Well, I had a slide on the treatment of PD and GAD. The treatment of GAD and panic disorder are the SSRIs. So I guess I've somehow or other lost that slide. So to just finish the discussion of panic disorder and GAD, the SSRIs are the drugs of that are approved for, and the SNRIs for the anxiety disorders. And so a couple of them are not actually FDA approved, but you can use them off-label if you document that. So, so the same medications we use to treat depression will be helpful in the anxiety disorders. Now, you run into the patient who maybe has been on alprazolam or lorazepam or clonazepam for years, who is also using alcohol or drugs. Opiates, can be really mixing things. And so they've been put on perhaps the benzo to treat their anxiety, but in fact, they're, risking serious consequences if they're using drugs along with it. So definitely want to be very, very, very cautious and not prescribe, not have people on benzos also using drugs. And there may come a time when a low dose, long acting anti-anxiety is going to be okay. But the buspirone is another one that can be used. It's not a controlled substance. So you always want to look for not controlled substances to be able to start with. And they're very, very effective in treating the anxiety disorders. SSRIs are. Okay, I'm sorry I missed that slide, but let's go on to OCD. So OCD, you can imagine if someone has constant thoughts of intrusive thoughts of something bad's going to happen, or all of this contamination, they're going to get ill, they're going to get, now I guess COVID is making things even worse for people with OCD, that's for sure. So those are intrusive thoughts. And then they will have compulsions, which are rituals of cleaning or hand washing or counting or checking, or both, or all of those. Or both obsessions and rituals, I'm sorry. And so people will often get started with using some sort of drug or alcohol to try to calm themselves, or marijuana to try to calm what's going on in their head, because they're very, very in much distress with OCD. The criteria is more than 1 hour a day with these thoughts or with these rituals, or if they have significant impairment in their life as a result of them. So the aim of the ritual is to neutralize the anxiety or distress. So that, like hand washing, checking things, counting things, spelling things on their hand, spelling things in their head, counting in their head, all those things are rituals that are done to reduce the anxiety that's occurring from the thoughts. And it's very much about a brain thing that's going on in the orbitofrontal cortex, the cingulate, and the striatum. So the basal ganglia, which has to do with movement, is the main area of physical involvement. 1.2% of the population, and also it is inherited, and asked about family history. It's 2 times the risk if the first degree relative has OCD, 10 times the risk if there was a childhood or onset, adolescent onset in their relative. Okay, next one. Go into treatment of that. Okay, so the SSRIs, SNRIs are also used for OCD, which is good news. Luvox is one that's not approved for depression. It's an SSRI, but it is approved for OCD. Pimipramine, it's only used second line, but it's an older tricyclic approved for OCD. And one of the key things here is to start low, as always, with the dose, but go high if it's tolerated, because OCD is not easy to get a good response unless the dose is pretty high, but it takes time to get there. So CBT helps, mindfulness-based CBT, and exposure response prevention, which gradually exposes the person to the things that they're most afraid of. And then they do relaxation and so forth to try to get control of it, get treatment. Okay, next one. Okay, you're on.
Okay, so what are we looking for here with post-traumatic stress disorder? One of the things that we recognize is that it has the 4 cluster symptoms there. And when we start to take that in and interview somebody, we really want to listen carefully to find out whether or not they are really feeling as though they're re-experiencing the event. And we want to watch carefully for their reactions, so they have a heightened arousal. So the other symptoms of avoidance, right, not distressing memories or negative thoughts, moods, and feelings, all of these are their DSM listed criteria for this disorder. But one of the problems here is that oftentimes when a patient comes in to screening, the symptoms of post-traumatic stress disorder can sometimes be mistaken for the symptoms of depression. So if we look at it here, we have lifetime rates of substance use disorder and post-traumatic stress disorder. Those are very high. Right? So when there's that comorbid situation going on there, what then happens is the person themselves has more cognitive difficulty, more social dysfunction. Again, that great risk for suicide, and these different the different severity that we're seeing and the greater disability really leaves them in a vulnerable state. So now they're coming in, we're starting to take a look for the symptomatology, and sometimes the thing that they present the most is the depressive aspect to it. And so really being able to screen properly and be able to look at these overlapping symptoms so that we're able to see that there's sort of there may be a subclinical traumatic stress reaction that's going on, but we want to be very clear so that when the patients who have PTSD, are truly identified, that their treatment can be set up properly, because the treatment for PTSD and for major depressive is very different. So getting that history, the history of trauma, is important. The screening is important. Early screening for trauma to identify it, that really helps you put everything onto the right track. So these are a number of different screening tools that can be utilized when we're in the clinic setting. We may want to just start off looking at what's the history of this person, what has happened in their life, what have their school years been like, what has their family interaction been like as they were growing up. We want to be able to understand that if they've had a traumatic event, what has it led to? And has it been covered up? So some of the screening tools here are very useful in uncovering, and they can often be used either in a primary care setting or in an intake setting. A lot of the research supports that when we look at treatment for substance use disorder and then co-occurring PTSD, once again, we're looking at an integrated treatment model. When the only patients with substance use disorder, and they are being treated in a setting where the rest of the idea of the PTSD is not being treated, where all of those symptoms are not being treated, we really have a disservice to that person. So we want to be able to make sure that we're not only using the types of treatment in the psychosocial aspects that are important, but that we're also looking for the ability to address the issues of substance use. We want to do them both at the same time. The integrated approach to treatment that addresses both these disorders really seems to be able to assist that patient. And there's a variety of different treatments that are being used for PTSD. We have both the non-exposure based treatments. These are integrated treatments, and there are quite a few different models here. What's important about each of these models is that each one sort of addresses different specific needs for different populations. And so whether it's addressing, as in the seeking safety for women, or it's addressing sexual trauma, each one has a different sort of framework to it. You're also seeing that the exposure-based treatments are getting a lot more, I was going to say exposure, but they're being used to a greater degree right now. And some of them are also even being used in the community-based settings. Along with that, you'll have pharmacological treatments. So there are quite a few. When it comes to pharmacology, one of the things that I do have to want to say was that as far as FDA approved, the Zoloft right now is the only one that is FDA approved, I think along with Paxil. And other medications have also been used. But many of them really need to have, they really need to have more research done on them. And I'm just being very aware of our time. So I'm going to go forward because I'd like Dr. Snow to be able to cover attention deficit disorder.
Imagine you see quite a few people in treatment that you think maybe this person has ADD, ADHD. The DSM-5 lumps everything into ADHD, but it doesn't mean that everyone has the hyperactivity. Especially adults tend to not have the hyperactive impulsivity part of it. So we have the inattentive type. You see 6 or more symptoms, so you can just kind of look through these. These are people who have trouble listening, so they have trouble keeping their mind focused on the therapy sessions. They don't complete tasks and get sidetracked. They might have difficulty with time management, finishing things. If things are really difficult, they won't get started. If you ask them to do a first step or a fourth step or something like that, they may never have the anxiety under control enough to be able to do it. They lose things, easily distracted, they get very forgetful, and they miss appointments. So all of that sounds like they're just being very irresponsible. But in fact, they may have had these problems, these concerns most of their life. So we do say that they need to have some of the symptoms at least present by the age of 12 and in 2 or more settings. So it's easier to diagnose, of course, children with it because they are young, and the adult, it's never too late to diagnose an adult with adult ADHD because it may be the first time in their life that they've been able to learn properly. I had patients who said they'd been a freshman in college for 6 years. I mean, that kind of thing that just, or they had never finished a book in their whole adulthood. Okay, go ahead to the next one, please, because we're running out of time. And one less, there you go. Okay, screening, the Vanderbilt and Connors mainly used with children, but if a young adult has, access to their parents, they can actually have that parent fill it out or at least ask them the questions. The Brown Adult ADHD scale is good, and then there's a self-report adult scale as well. The genetics, it's definitely 70 to 80% controlled by genetics. That means almost everyone who has ADHD has some family history of the illness. It's a D4, D5 receptor genes involved. Dopamine and norepinephrine dysregulation, that's why the medications are directly have helped the prefrontal cortex to be able to work better and because there's an efficient information processing in that prefrontal cortex. There are a few environmental factors that can also contribute and cause ADHD, but they're really not at the point where we have full research to be able to say, oh yes, if your mom smoked during pregnancy, you have ADHD. It's just some contributing factors that we know could possibly be why that child and that adult has ADHD. Okay, next one. Treatment will help increase attention, decrease procrastination, help with any kind of hyperactivity they may be having or impulsivity. So the stimulants are first line. Of course, that's a class 2 controlled substance, and we have some risks with anyone you're treating for substance use disorders. So Adderall and Adderall XR, those are amphetamine salt products, and then methylphenidate is another category. They're short-acting, long-acting patches. There's all sorts of, and they're pretty much all generic, methylphenidate. There may be 1 or 2 that are not. Vyvanse is not generic. It's less dexamphetamine. It's considered to perhaps be a little bit safer because it's long-acting and it's once a day. But any of the XR or long-acting products are a little safer for anyone that you're worried about drug use. Of course, you can do drug screens, do other methods of safety for that particular patient. Non-stimulants are norepinephrine reuptake inhibitors, Strattera being one, which is atomoxetine, and then a new one is viloxazine ER. Quellbri is the trade name for that. So that increases norepinephrine, dopamine in the prefrontal cortex. Those are the 2 neurotransmitters that are not working very well in people with ADHD. They have an under-functioning of the prefrontal cortex, and they can't utilize norepinephrine and dopamine. There's a risk of suicide ideation and mania if they do have bipolar disorder and you're treating with a non-stimulant, and a risk of withdrawal if they miss a dose. So these people have to stay on these non-stimulants every day to prevent withdrawal, whereas the stimulants are in and out in one day. So they could have what they call drug-free holiday and not have a medication on the weekends or something like that if they really wanted to. Also, the alpha-2A adrenergic agonists, guanfacine and clonidine, are used either as adjunctive or as primary medications for, and they are not controlled substances either. Bupropion has an off-label use for ADHD. It's mildly effective, but it's certainly not one that's, treats all the symptoms, but it can be helpful. Okay, let's move on to one more slide, I'm sorry. So children with ADHD are increased risk for substance use disorders, especially the literature towards alcohol, tobacco, cannabis, and cocaine especially. And 15% of teens and young adults have co-occurring SUDs that have ADHD. So the impulsivity may increase the risk of starting substance use. Of course, I think that's how a lot of our ADHD kids get started with, using drugs at a very young age. Assess the ADHD in periods of abstinence. So you need to ask them, did these symptoms start early in your life and when you weren't using drugs or alcohol? If they were present before the substance use started, likely it's ADHD. It's recommended that you get as much collateral data as possible, which is sometimes difficult. And remember to make it a priority really to treat it. So it's not like a secondary disorder that shouldn't be addressed. It needs to be addressed with medication and psychosocial intervention. Okay, next one is our case study. Do you want to read that?
I'll read it.
Could we hold the case study because we're past time?
We can leave the case study, and it is in tips, and we'll put it up. I think the take-home messages that we really wanted to just bring out was that screening tools are used to identify the symptoms of co-occurring disorder, but a full psychiatric assessment is still needed to confirm a diagnosis. And that family history, patient history, collateral history, all extremely important, making sure you take the time to do that. Referral and appropriate treatment should be started right away, and that an integrated approach is really the best approach.
Thank you both for a wonderful presentation. I thought you did like mental health advanced practice nursing 101, a course in an hour. It was excellent.
Yeah,
it was
whole
excellent.
semester.
It was a train run, just put it that way.
Great information.
And it was also a different in not sharing everything.
Yeah, it was incredible information. I'll tell you, I learned a lot. It was great. So let me see what's in the chat box. And you're getting a lot of comments. That's what you're getting. Great presentation, ladies. Thank you. Excellent presentation. That's what's in the chat box so far. If anyone does have any questions for Ginny or Diane, just post them in the chat box and I'll read them and they will respond. But the information was excellent, really.
Well, I will say it's something Diane and I both really enjoyed putting together. And we're glad that it's there. We thought about it a lot, and we said we actually could make a whole series of webinars out of just this.
Well, here's what I'm reading. Wonderful. Will this be available to see afterwards? Yes, you will have access to the slides, usually within a couple days. This was awesome. Thank you. Love telling patients to keep tags on, Diane.
Keep what?
Looks like tags on. Love
telling
patients to keep tags on.
It's on those clothes.
And just so everyone knows, this is being recorded, so the recording will be available on the website as well. I think it would be great to have advanced concepts of substance use disorders and psychiatric disorders. That may be a future webinar.
We'll have to do that.
Yeah. When you mentioned if mother smoked during pregnancy, what would she have smoked?
Oh, well, cigarettes. Nicotine is what I was referring to.
That's what I thought would be
the
literature.
Yeah. And low birth weight, which contributes to low birth weight, which can be a possible etiological factor with ADHD. It's low birth weight and hypoxia.
I guess, I do have a question. So here's my question. Our psychiatrist does, you know, you'll have someone who leaves detox, and when they go to our partial hospital program, then he does a very intense psychiatric eval with a bunch of scales. And of course, ADHD scales is one. And then, you know, he diagnoses them with ADHD. But when you actually talk to the patients, sometimes they really, to me, don't seem to have ADHD. So I guess my question is, would you not be seeing, a lot of times when they're done detox for a little while, you'll see like post-acute withdrawal symptoms where I think people do have difficulty focusing. Any thoughts on that?
Well, it goes back to, has there been a period in their life when they weren't using drugs or alcohol and they had these symptoms? And you don't have to necessarily have them. So you shouldn't make the diagnosis based on what you're seeing in treatment. You should do it on history and how they learned in school. And did they have trouble with, you know, paying attention? Did they have, you know, all those things that show inattentiveness? And were they hyperactive? You know, did they have trouble staying in their seats and throwing paper airplane, you know, all that kind of stuff? People will say, oh yeah, that was me. I couldn't sit still. And they might have had the hyperactive type. So you confirm it. You don't really confirm it by the present symptoms so much as looking back, because it has to be there. You can't treat them. You should never treat somebody for ADD who doesn't have it. Really, you really shouldn't. And I guess there's exceptions to that. If you know, some kind of treatment-resistant depression, sometimes the stimulants may help in rare cases, you know, but really to give someone in treatment a stimulant or even a non-stimulant for ADD who you haven't had that chance to really get a good history, I don't think is really correct. But if they report, and the other thing that, of course, everybody says is they can read online or in a book and give a really good history when they don't have it, if they're drug seeking, I don't know if that's the correct term, but if they're seeking a stimulant prescription, there are people who will go to multiple providers and try. Thank goodness we have some things in place now to check, you know, to make sure that that doesn't happen, but it still happens from time to time. So they will, especially I was practicing in a college town, and right around exams, everybody said they had ADD, right? Because they wanted the stimulants to be able to study better. That's not a good reason to prescribe stimulants. So you make sure and document, because it's not safe to use these very powerful controlled substances, that's for sure. You know, unless there's a clear history, childhood history. That's my 2 cents worth.
That's great. No, that's great. So someone said, when we back to the pregnancy question with what was smoked, someone says same with smoking marijuana or meth, crack cocaine too, question mark.
I don't know that there's been, I would have to look that up, but I think probably I would say if it affected the oxygen level of the baby, of the infant that's growing, then the embryo and so forth, I would say yes.
Okay. Again, another great presentation. Thank you both. And just a comment, also really seeing a new quote, animal quote with polysubstances, especially opioid.
Absolutely.
Yeah. Well, again, thank you for a wonderful presentation. For everyone here, make sure you fill your evaluation out to get your contact hours. If you are not an ASAN member, we really encourage you to join. It's a great organization. The membership fee is very reasonable. We will be doing a webinar monthly starting in September. And just to mention, next week's webinar will also be excellent. That's Dr. Ferguson looking at drug screening and toxicology. So I think that will be a really exciting lecture as well. Yeah. Thank you, Ginny and Diane, again. It was wonderful. We really appreciate it.
Thanks everybody for attending.
Thank you. Goodbye, everyone.
Bye.
Bye.